I'm very pleased to be with you virtually today to talk about optimizing outcomes of orthopedic surgery. This is my disclosure for research support, consulting, and speaking. And these are the objectives today. I'd like to review the effects of osteoporosis and osteoporosis medications on bone healing. I will describe potential uses of anabolic and anti-resorptive agents before and after orthopedic surgery, and identify strategies to optimize surgical outcomes and reduce the risk of periprosthetic fractures. First, I'll talk about bone healing. There are two primary mechanisms for fracture healing. The first and the most common is called indirect or secondary fracture healing. This involves non-operative fractures or fixation with micro motion with an intramedullary nail or external fixation. Here we have intramembranous ossification that precedes and overlaps endochondral ossification. Ultimately, there's bony bridging of the fracture gap and remodeling to restore bone anatomy, as you see in the image above. The second and less common mechanism for fracture healing is called direct or primary fracture healing. Here we have anatomical reduction of the fracture with no gap, as occurs with rigid fixation or stress fractures. There is mechanical continuity of the cortex on opposite sides of the fracture with intramembranous ossification. Direct bone remodeling of lamellar bone eversion systems and blood vessels occurs with this type of fracture healing. All of us are concerned about issues with delayed union and non-union. No orthopedist wants this to happen, and certainly it's difficult for the patient. Most long bone fractures heal in 6 to 8 weeks. This is often defined as formation of a bony callus with bridging. Unfortunately, about 5 to 10% of fractures have delayed union or non-union, with reports of rates as high as 17% non-union for some long bone fractures. There's no standard definition of delayed healing, although the FDA in the US has defined non-union as failure to heal by 9 months or lack of healing progression by 3 months. This is one classification of non-union into two categories. The first is called hypervascular or hypertrophic. Here we have large cartilaginous callus lacking a bony bridge that's often due to instability of fracture fixation. And the therapeutic approach to this is to optimize fixation. The other category of non-union is avascular or atrophic, where there's minimal to absent callus formation. Here, therapeutic approaches include biological modifiers such as a bone graft, bone morphogenetic proteins, FGF2, and possibly anabolic drugs, which I'll talk about in just a few minutes. There are risk factors, as you all know, for non-union. They're more common with certain types of fractures, such as fractures of the tibia, open fractures, comminuted fractures, and transverse fractures. Systemic factors can increase the chances of non-union. This includes advanced age, cigarette smoking, excess alcohol intake, poor nutrition, having diabetes, and taking non-steroidal anti-inflammatory drugs. And there are local factors that increase the risk of non-union. These include infection, soft tissue injury, compartment syndrome, or injury to the periosteum or endosteum, as well as poor vascularization. Here is a nice recently published study that reviews the effects of osteoporosis on fracture healing. I often get questions from patients as to whether having osteoporosis will interfere with the healing of fractures or have effects on surgery. Here we have 5 clinical studies that were reviewed, 3 prospective and 2 retrospective. 2 studies identified osteoporosis as a risk factor for impaired fracture healing, and 3 did not. You see some of those references below. The conclusion of this analysis is that there were many limitations of the studies that were reviewed and inconsistent findings. It was concluded that osteoporosis may impair fracture healing, but the convincing evidence is lacking that this is the case. So I would say there's still a little bit of uncertainty as to whether osteoporosis impairs fracture healing, and a definite lack of overwhelming evidence to support the opinion that it might impair fracture healing. Now, what about osteoporosis treatments in fracture healing? Here we see a review of 26 clinical studies and 3 meta-analyses, and it was concluded from this study that there's no clearly positive or negative effect of anti-resorptive therapies on fracture healing. So there's really no evidence to support the idea that bisphosphonates or denosumab, for example, have any adverse effects on bone healing. Anabolic therapy has no negative effects on bone healing and possible beneficial effects. Parathyroid hormone-related therapeutic agents decreased the time to union in several studies with no effect on delayed union or non-union. There is a rationale for using anabolic agents to enhance fracture healing. With teriparatide and abaloparatide, there is acceleration of chondrocyte recruitment and differentiation that enhances early endochondral ossification and improves biomechanical properties of fracture callus, along with upregulation of bone growth factors. With romosozumab, there's activation of the Wnt beta-catenin pathway that's associated with endochondral ossification, and it's known that endogenous inhibitors of Wnt signaling may impair fracture healing. So for these reasons, anabolic agents have been investigated as potential tools that we might use to improve the chances of fracture healing. These are the 3 anabolic agents that we have in the US. Teriparatide is a PTH receptor agonist that has now been approved for about 21 years. It has FDA approval for the treatment of postmenopausal women with osteoporosis, to increase bone mass in men with osteoporosis, and to treat men and women with osteoporosis associated with long-term glucocorticoid therapy. And all of these are modified by saying these are patients at high risk for fracture. Abaloparatide is also a PTH receptor agonist that was approved about 6 years ago. It's used to treat postmenopausal women with osteoporosis and to increase bone density in men with osteoporosis. And the newest of the anabolic agents is romosozumab, which is a humanized monoclonal antibody to sclerostin that was approved in 2019. And this has FDA approval for the treatment of osteoporosis in postmenopausal women at high risk for fracture. There is evidence from animal studies that anabolic agents enhance fracture healing. The study designs are generally rat or mouse models with osteotomy of the femur or tibia in non-osteoporotic males and females and in osteoporotic female rodents. The results of these studies are as follows. Most of them show benefit of PTH receptor agonists and benefit of sclerostin inhibition with acceleration of fracture healing, increased biomechanical strength, and increased bone mineral density and bone mineral content. So very promising, at least for animal studies, that anabolic agents might be useful in humans. However, it's not entirely clear in human studies. We have conflicting data on the effects of PTH on fracture healing in human studies. There was one non-randomized study showing that 100% of pelvic fracture patients given PTH 1 to 84 healed within 12 weeks versus 68% of controls. With cortical bridging by CT scanning, reduced pain, and better timed up and go performance. And this study was published in 2011. A post hoc analysis of a randomized controlled trial showed shorter healing time in 3 of 4 cortices by X-ray after distal radius fractures with teriparatide 20 micrograms, which is the dose that's normally used for osteoporosis, but not with the 40 microgram dose, and this was compared with placebo. However, other studies have shown no improvement, and uncertainty remains on the benefits of anabolic therapy for fracture healing. So, given the favorable findings with animal studies and conflicting data with human studies, the question remains, does anabolic therapy really improve fracture healing or not? Romosozumab, the newest of the anabolic agents, does not enhance fracture healing in humans, according to 2 randomized controlled trials. In the first one, at the top bullet, romosozumab did not improve fracture healing-related outcomes or radiographic healing in a double-blind, randomized, placebo-controlled dose-ranging study in over 300 patients with hip fractures who were treated with open reduction and internal fixation. In the bottom bullet, you see that romosozumab did not improve radiographic fracture healing or physical function in a double-blind, randomized, placebo-controlled dose-finding study of over 400 patients who had tibial shaft fractures. So based on these studies, I think we could feel fairly confident that romosozumab does not improve fracture healing, although it does not impair fracture healing either. So I think we can think of romosozumab as being a neutral agent in terms of fracture healing. Questions have also come up about whether teriparatide might be useful for healing of atypical femur fractures associated with anti-resorptive therapy, or for healing of osteonecrosis of the jaw. In the left-hand panel, you see reference to some information showing inconsistent benefit of teriparatide in patients with AFF. Several retrospective studies suggest faster healing time and lower rates of delayed union and non-union, reviewed in the study by Yoon in 2020. Another very small prospective study with 14 patients who had AFF while on a bisphosphonate and were then treated with teriparatide for 24 months showed inconsistent findings. There was increased bone density at the lumbar spine, but not the hip, and an increase in bone turnover markers, as you would expect with such an anabolic agent. CT scans were done at 24 months, showing healing in 6 patients, partial healing in 3 patients, and unchanged in 2 patients with non-union in 1 patient. The limitations of this information is that AFF is very rare. Prospective randomized controlled trial is difficult or almost impossible to conduct because of the rarity of this condition. What about osteonecrosis of the jaw? In the right-hand panel, there are studies showing inconclusive benefit. There are several case reports of benefits in the first bullet that you see. and a case series of 27 patients who were partly randomized to teriparatide or no teriparatide showed faster healing time with teriparatide. But there's limitations here as well as with the studies for AFF. Due to the extreme rarity of ONJ, a prospective randomized controlled trial is difficult or impossible to conduct. And most patients with ONJ have cancer and may not be candidates for teriparatide in the first place. Another question that has arisen is whether romosozumab can cause atypical femur fractures and osteonecrosis of the jaw. In the FRAME study, which was the pivotal fracture trial with 1 year of romosozumab versus placebo, followed by 1 year of denosumab for both groups in women with postmenopausal osteoporosis, there was one report of AFF, which occurred 3.5 months after the first dose of romosozumab, with this patient having prodromal pain before the start of the study, suggesting that the AFF may have been beginning before ever receiving romosozumab. For ONJ, there were 2 cases. One occurred 12 months after the first dose of romosozumab and was associated with ill-fitting dentures, and another after 12 months of Romo and 1 dose of denosumab following the tooth extraction where there was osteomyelitis. So again, there are mitigating factors with these patients adjudicated to have ONJ that may or may not have been related to romosozumab. In the ARCH study, where patients received romosozumab or alendronate followed by open label alendronate in women with postmenopausal osteoporosis, there were no reports of AFF or ONJ in the double-blind period. And with the open label alendronate part of the study, there were 6 reports of AFF and 2 of ONJ. And finally, in the BRIDGE study, which was a placebo-controlled trial of romosozumab in men going on for 1 year, there were no reports of AFF or ONJ. So I would say there have been reports of both of these with romosozumab, but the information concerning causality is still a little bit unclear. So this brings up the question, why are anabolic agents consistently effective for fracture healing in animal studies, but not in humans? And my answer to that is, I don't really know. There are many mitigating factors. Fracture healing studies are notoriously difficult to conduct. Studies in humans have looked at different types of fractures at different skeletal sites. They may be stress fractures, periprosthetic fractures, atypical femur fractures, different levels of trauma. There may or may not be open reduction and internal fixation. The timing of the start of anabolic therapy has varied. Sometimes it's immediately after the fracture, sometimes later on, sometimes not until there's delayed union or non-union. The patient population varies. Some studies look at young, healthy adults, some geriatric populations, some in patients with osteoporosis. Measurement of fracture healing differs. Sometimes it's looking at cortical bridging, sometimes levels of pain, sometimes physical function. And the measurements are different. Sometimes it's X-rays, CT scans, sometimes quality of life questionnaire, or levels of physical activity. What about stress fractures? Athletes and military recruits get stress fractures. On the left, you see Rafa Nadal last year having a stress fracture of the left third rib during an important tournament. Pitcher for the Boston Red Sox had to have a period of rest because of a stress fracture of the rib. And military recruits across the world are at high risk for stress fractures due to repetitive trauma from basic training. What do all these people have in common? It's this: they all want to return to work fast. And in fact, all of us who may have a stress fracture want to heal up quickly. So, does anabolic therapy improve fracture healing in young, healthy adults? There are anecdotal case reports and small clinical trials of faster healing time and return to work using teriparatide in young adults with stress fractures. Teriparatide, at least in the US, is actually fairly commonly used off-label to treat elite athletes with fractures, but uncertainty about effectiveness continues. There are two randomized controlled trials that are in progress, one called the STRONG study, another called the RETURN study. The results on these studies are not yet available, but hopefully over the coming years, we'll have more solid information on the use of teriparatide for patients with stress fractures. What about periprosthetic bone loss and periprosthetic fractures? None of us want to see periprosthetic fractures. One of the very disturbing things for the orthopedic surgeon as well as the patient if a fracture occurs intraoperatively. Here we have a retrospective review of over 32,000 patients with primary total hip arthroplasty at the Mayo Clinic. There was a 1.7% rate of intraoperative femur fractures. They were greatly more common with uncemented stem placement and only a small number with cemented stems. There were 557 postoperative periprosthetic femur fractures. Again, at least a few more with uncemented stem placement compared with cemented stem placement. The take-home message from this is that intraoperative and postoperative fractures are far more likely to occur with uncemented stems. And the message was to consider cemented stems in patients with osteoporosis, those over age 75, patients with inflammatory arthritis, abnormal proximal femur morphology, conversion of failed hip fixation, and with femoral neck fractures. Bone loss can occur very rapidly after total hip arthroplasty and with total knee arthroplasty. The BMD loss after total hips is common and associated with aseptic loosening, periprosthetic fractures, and the need for revision surgery. Here we have a meta-analysis and review of 9 randomized controlled trials with 480 total hip patients receiving either Zol or denosumab compared with those getting placebo. And the primary outcome was BMD changed with DEXA in the Gruen zones that you see in the image on the right. And it was found that Zol and denosumab significantly reduced bone loss, especially in Gruen zones 1, 2, 6, and 7, with no serious adverse effects observed. And there's a rapid rate of bone turnover in bone in the cortex that's adjacent to the stem, and this clearly is reduced when treatment with a potent antiresorptive agent is used. How about optimizing outcomes of spine surgery? The ISCD, the International Society for Clinical Densitometry, has some official positions that bone health assessment should be considered prior to elective orthopedic and spine surgery, including BMD testing, according to your local guidelines. They recommend considering vertebral fracture assessment, either by DEXA or spine imaging by other means before spine surgery. When poor bone quality is identified during surgery, bone health assessment, including DEXA, is indicated. And they mention opportunistic CT-based data that can be used to estimate the likelihood of osteoporosis with L1 Hounsfield units less than 100 being highly suggestive of osteoporosis and most likely to be normal when Hounsfield units are greater than 150. And they go on to state that treatment based on DEXA-proven osteoporosis may mitigate bone-related complications and improve outcomes in elective orthopedic surgery. How well do orthopedists do this? Well, this is a survey of 349 spine surgeries surgeons that found that only 20% screened patients for osteoporosis prior to surgery. Another study showed that 91% of patients having arthroplasty or spine surgery had indications for osteoporosis drug therapy. We know that patients with poor bone health are at increased risk of pedicle screw loosening, instrumentation failure, pseudoarthrosis, vertebral fractures, proximal junctional kyphosis, and revision surgery. And we know that pre-op evaluation and treatment can reduce the risk of these complications. So how can we improve outcomes with spine surgery? This was addressed here in a consensus statement providing best practice guidelines for evaluation for elective adult spine reconstruction. And it was suggested here that formal bone health evaluation be done for all patients age 65 and older. For younger patients between 50 and 64 that have any one of 12 risk factors listed below, and for patients under age 50 with any one of 5 risk factors that you see listed below. And the ways to do assessment are with DEXA of the spine and hip, TBS or trabecular bone score, and spine imaging. Lateral spine x-rays may be used for screening for vertebral fractures. Opportunistic lumbar spine CT may be helpful. Serum 25-hydroxy vitamin D should be measured. And all patients with poor bone health should be evaluated by an experienced bone health provider. There were guidelines for treatment prior to elective surgery for all patients. Non-pharmacological measures such as adequate calcium and vitamin D intake should be instigated. For patients with poor bone health, the first choice to improve outcomes is anabolic therapy with either teriparatide or abaloparatide starting 2 to 6 months preoperatively and continuing at least 8 months post-op, followed by an antiresorptive agent. The second choice is antiresorptive therapy with denosumab or bisphosphonate. They also stated there's no need to withhold treatment in the immediate post-op period. These are the benefits of doing this. With anabolic therapy, there's reduced pedicle screw loosening, increased fusion rates, shorter time to union, increased rate of union, reduced rod breakage, increased insertional torque, and decreased adjacent segment disease. The evidence is a little bit more mixed for antiresorptive therapy, but some studies have shown improved fusion and decreased complications with alendronate and zoledronic acid. And there was a single study showing that teriparatide combined with denosumab is superior to teriparatide alone. We have very little data with abaloparatide, but it's generally assumed to be similar to teriparatide. And romosozumab has not been around long enough to know very much, and no data has been reported. So just to summarize, there is no convincing evidence that osteoporosis or osteoporosis medications impair fracture healing. With antiresorptive medications, there's no evidence of benefit for fracture healing. They can reduce periprosthetic osteolysis and reduce implant migration and may reduce the risk of periprosthetic fractures. With anabolic agent, there is possible benefit of PTH analogs, teriparatide and abaloparatide for fracture healing. With teriparatide, there are case reports of benefit for fracture healing, atypical femur fractures, and osteonecrosis of the jaw, with a higher level of evidence for benefit with spine surgery. With abaloparatide, there's far less information than with teriparatide, but probably similar. And with romosozumab, there's no evidence for benefit with fracture healing and sparse data regarding AFF, ONJ, and spine surgery. So thank you for your attention.